Okay, I'm going to start the lecture. Hello everybody. My name is Vatsal Patel, and I'm going to look at the time lecture. We're on time, 3 minutes. Of today's lecture. So, my name is Vatsal Patel. I'm a general radiation oncologist here in Las Vegas. I graduated in 2019. Yesterday, I did the lecture on anal cancer and colon cancer. Today, we're going to do a lecture on biliary tract cancer. Again, a low yield topic, just like colon cancer, but there's quite a bit of material to cover. I tried to make this as comprehensive as possible, including the NCCN flowcharts. We're going to go over all of that within an hour. Um, uh, Hepatocellular carcinoma is not covered in this lecture because that will be covered tomorrow. So today we're going to cover intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder adenocarcinoma. So those all three uh, comprise when we say biliary tract cancer. Those three types. So, all right. Hepatobiliary tumors comprise of three types of cancer, depending on the anatomic structure. They arise out of liver, gallbladder, and bile ducts. Today we are covering three. Liver, we're going to do tomorrow. So liver is hepatocellular carcinoma. For gallbladder, we are talking gallbladder adenocarcinoma. There are other histologies as well, but 75% of these cases are adenocarcinoma. And bile duct, intrahepatic and extrahepatic cholangiocarcinoma. By, gallbladder, gallbladder and bile duct carcinomas are collectively called biliary tract cancers. Cholangiocarcinoma account for 3 to 4% of all the GI malignancies. Gallbladder as well as bile duct tumors are highly lethal. Epidemiology in 2023, an estimated 41,210 cases uh, 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 occurred in the US. This included liver cancer and intrahepatic bile cancer, and an additional 12,000 people were diagnosed with gallbladder cancer or other BTCs. Approximately over 29,000 deaths occurred from liver or intrahepatic bile cancer, and 4,500 plus deaths occurred due to gallbladder cancer. Two-thirds of the hepatobiliary cases are gallbladder cancers, and gallbladder cancers are the most common biliary tract tumors as a group. Typical presentation of age is between 50 to 70 years of age, may occur 2 decades earlier in patients with primary sclerosis, cholangitis. Extrahepatic cholangiocarcinoma are more common in men, are found to be, the rate is higher in primary sclerosing cholangitis patients. So these are the risk factors for, when I say ICC, it's intrahepatic cholangiocarcinoma, and ACC is extrahepatic. These are the main risk factors: primary sclerosing cholangitis, ulcerative colitis, fibropolycystic liver disease, Corelli syndrome, choledochal cyst. Also, parasitic infections, including Opis torquis and clonorchis, Lynch syndrome, biliary papillomatosis, diabetes mellitus, um, uh, obesity, HIV, H. pylori, and toxic exposures such as auto, rubber, chemical, wood industries, and etc. So this is a busy slide, and a lot of the slides are busy, but I'll try to summarize them in my own words. So risk factors but this is the material we can go over after we're done with the lecture, but I'm going to cover all of it. Risk factors for intra and extrahepatic cholangiocarcinoma. So there are no predisposing factors that are identified in most patients with cholangiocarcinoma, and evidence that particular risk factors may be associated with the disease in some patients. So risk factors, just like those for gallbladder cancer, which we're going to cover separately, are associated in the presence of chronic inflammation. So the main theme is chronic inflammation. So that can happen from primary sclerosing cholangitis, chronic calculi along the bile duct tract, we call it hepatolithiasis, choledochal cyst, and liver fluke infections. These are well-established factors for cholangiocarcinoma. Cholelithiasis, which is a huge and the most prevalent risk factor for gallbladder cancer, is not thought to be linked with cholangiocarcinoma. Um, and inflammatory bowel disease may be a risk factor, although this association is confounded by primary sclerosing cholangitis. Other risk factors tend to be for for intrahepatic cholangiocarcinoma, because it's within the liver, it does make sense that some of the risk factors are mixed with those that are similar to the risk factors for hepatocellular carcinoma, such as hepatitis B, virus infection, cirrhosis, diabetes, obesity, alcohol, and tobacco. And the systematic review and meta-analysis reported that the strongest risk factors for both intra and extrahepatic cholangiocarcinoma included biliary cysts and stone, cirrhosis, HBV, and hepatitis C virus. Obstructive jaundice. So when you see the word jaundice for biliary tract tumors, you know you're dealing with an advanced disease. It is at least a T3 or T4 disease. That's when it's causing the jaundice. And that carries with it quite a bit of poor prognosis or worse prognosis at every front. And we'll go over that in detail, but what are the signs and symptoms of obstructive jaundice? You will see an elevated alkaline phosphatase, elevated bilirubin, dark urine, gray stools, pruritus, scleral picturus, and jaundice. These are the classic symptoms we learned about in medical school, like what it means, what are the signs and symptoms of obstructive jaundice. Same here, abdominal pain. It could be vague in some patients, but really, clinically, what we're looking for is right upper quadrant abdominal pain that is persistent and doesn't go away. You could also have like a colic kind of pain, come and go kind of pain that mimics a gallbladder stone issue, cholelithiasis, but actually it's the cancer. Weight loss, fever, and cholangitis. Cholangitis would be unusual, but it can happen. Cholangiocarcinoma, what's the anatomy? What does it look like? So extrahepatic and intrahepatic, it's two separate, right? So within extrahepatic, so extra meaning outside of the liver, or getting to the outside of the liver. So it's extrahepatic, so there is perihilar and distal. Perihilar is from right and left extrahepatic branches to below the cystic duct. And it has a Bismuth classification. I don't think you need to know for the boards, but you can look it up. I'll be dumbfounded if they really tested you and stuff like that. Distal would be from the cystic duct to the distal bile duct entering into the duodenum. So if you look at it from anatomic standpoint and prognosis standpoint, if something is distal and outside of the liver, it is going to help you in terms of surgical resection, and you don't have to deal with invasion of a lot of structures that you would have to deal with if the tumor was intrahepatic. So that is prognostic as well. Intrahepatic, it involves the right and the left intrahepatic branches and the second and the third order branches. Each has its own staging system, and it's intimidating. And most people, I know when I took the board, I really didn't care much about the staging for this. It's a peripheral topic, but it's very logical. If you just follow the anatomy, staging will be easy. And this is just a quick diagram on what percentage of cases occur in what area. So you have intrahepatic, which are fewer cases, 7 to 10%. Then you have extrahepatic, which includes the perihilar and the distal two pieces. Perihilar accounts for 75%, 66% of which occur at the bifurcation. And you have 15 to 20% of cases with the distal extrahepatic parts. Bile duct anatomy, you can go over that when you have time. And then you have bile duct pathology. Adenocarcinomas account for 90% of the cases. These are CK7, CK20 positive. Remember, these tumor markers we also used for colon cancer yesterday. Colon cancer is a CK, it's also a CK20 positive tumor, just like Merkel cell carcinoma, but it is CK7 negative. Sclerosing. These are the histological features, and as you can see, just remember that sclerosing and nodular both have low resectability rates. Nodular in particular is highly invasive. Then you have papillary, which is the rarest form, but it also is the one with the highest resectability rate because it's typically diagnosed at an early stage. I couldn't find much on it. I mean, if you were to do literature review, you might find stuff on this, but this is something that I found interesting. So what are the labs you should be doing? So you really need a good assessment. This is for bile duct, but we'll have a separate discussion for gallbladder. Liver function test is important to assess the hepatic reserve. And you should also get tumor markers CEA and CA 1919. Of note, CEA is non-specific, and so is CA 19.9. So these two markers should not be used for diagnostic purposes when you are dealing with biliary tract tumor. These are simply to know the baseline. PT, PTT, for imaging, you would have a CT chest, abdomen, pelvis, a 4-phase liver CT, and an MRI of the abdomen with MRCP. ERCP is only done, so MRCP is always preferred over ERCP unless you are dealing with a jaundice patient situation where ERCP would be done in order to relieve the jaundice and obtain tissue. PTC if ERCP is not feasible. So generally MRCP followed by ERCP, or so in terms of the preference of what is preferred modality for evaluation is MRCP. If MRCP, if you need to have a relief from jaundice, then only you would be doing ERCP over MRCP. And PTC is the last option if for therapeutic reasons, excuse me, you need, if ERCP is not feasible, then you would do PT. So perihilar. So there is perihilar and then there is distal stitching. So these are both. So perihilar, don't get lost. This is for extra hepatic cholangiocarcinoma, right? So you have perihilar, you have distal. So perihilar, think of this as, I think it's, if you just look at the anatomy, T1 is basically confined to the bile duct, right? T2 is extending or invasion beyond the wall of the bile duct to the surrounding adipose tissue, or you are invading, the tumor is invading into the adjacent hepatic parenchyma. So either it's the adipose tissue or it is the hepatic parenchyma. And because you have perihilar region, you have access to the liver tissue still. So that's T2. So T2, A and B is basically that separation. Either you're invading into tissue outside of the bile duct and it's only adipose tissue, or if you're invading, if you're looking at invasion into the hepatic parenchyma, in which case, obviously, it would be a more advanced version of T2. So that would be T2B. And then T3 and T4 are very important because this is what makes a locally advanced tumor. Because now we are starting to engage vessels. For T3, so if you see the word main portal vein or bilateral or common hepatic artery, you know you're dealing with the T4. So that's the strategy. If you see the words the main vessel invading into the main vessel, main portal vein or the common hepatic artery, those two are the main ones in liver. So that would be T4. Or if there is invasion into the branches bilaterally, not unilaterally, but bilaterally, that would be T4 too. Or if you see some complex variation like unilateral second order biliary radicals and bilaterally with contralateral. So if you see a unilateral with bilateral or a contralateral situation, that is also T4. So anything less than that, like if you're only dealing with unilateral branch, whether it's from the portal vein or the common hepatic artery, that's a T4. Unilateral branch, not the main branch, simply T3. T4, either bilateral or unilateral and combination of contralateral, or just attacking the main branch, the main vessel, that would be T4. N1, N2, you have N1 for nodal staging and N2 for N1 and N2. So 2 to 3 lymph nodes typically involving these areas mentioned here, 4 or more would be N2. So distal, here you don't have to deal with the hepatic parenchyma. So how are you going to do it? So the only thing you can look at is the depth. So 5 millimeter, less than 5 millimeter is T1, 5 to 12 millimeter is T2, more than 12, greater than 12 millimeter would be T3, and T4, then you're starting to look at again the vessel. Here, since you're further out, celiac axis would make sense. Superior mesenteric artery is right next to it. That would make sense. And then you have the common hepatic artery, which is also closer. So those are the closed vessels anatomically for the distal area for the bile duct. So those all make sense for T4. And then N1 is 1 to 3 lymph nodes, and 4 or more would be N2. That's the thing. Bile duct recurrence, local regional recurrence risk is 60%. distant is 40%, pretty high, both of them. Surgery is the only cure. Unfortunately, it's not possible for most cases that are diagnosed in advanced stage. Better survival is associated with distant tumors, and I covered that because you don't have access in most cases to the hepatic parenchyma unless it's really advanced. So better survival is associated with the distal tumors rather than mid or proximal lesions due to increased resection rate. Goal is complete resection with negative margins and regional lymphadenectomy. So remember, this is a radiation exam. What are the times you're actually going to do radiation? So either it's an unresectable disease, in which case patients are going to get chemo anyway, and the role of radiation would be palliative, but you give a pretty high dose, anywhere from 60 to 70 gray. We'll go over that. Or it was an R1 resection or a node positive tumor. So those are all the criteria for using radiation, but there is evidence, but it's very meager, and it comes with a list of options, meaning it's not like a standard of care practice to do it, but it is an option that is given to patients, even on limited data. Diagnostic laparoscopy should be performed. Again, this is a bit different from gallbladder cancers, where for earlier stage cancers, you don't need to perform that. But occasionally, combined pancreatic and hepatic resections are required. So for distal tumors, what do you need? Think of pancreatic cancer, right? So it's like same thing. Whipple, pancreaticoduodenectomy. For mid, rarely a bile duct resection with lymphadenectomy, likely will require a Whipple or hepatic resection. Again, depends on which organs are being invaded, the extent of the resection. You want a clean margin. Okay, so for hilar, for perihilar tumors, tumor will need removal along with the involved biliary tree and the involved liver lobe. Very complicated. You have contralateral liver requires intact arterial and portal flow as well as biliary drainage. Adequate future liver remnant. You want to make sure you don't kill the patient by taking out all of the liver. So liver transplantation would also be a consideration in those situations. Then Roux-en-Y reconstruction, portal lymphadenectomy, vascular reconstruction may be required. I don't think you need to know the details. Just know that the more advanced the tumor, the more areas need to get resected for a clear margin. Resectability, distal and mid, absence of gross nodal or liver mets. So what are the criteria for resection? All right, so we prefer not to have lymph nodes and we prefer not to have liver mets. I mean, if we have liver mets, it's game over. For gross nodes, you could do a neoadjuvant chemotherapy, downstage the disease, and make it resected, right? I mean, I guess you could see the same thing for liver mets, but you get the point. Absence of invasion of the, so if you have the main portal vein or the common hepatic artery, obviously that's a T4 disease, or you're looking at a T3, T4, depending on if only the branches are involved. So those also factor in resection, and only a surgeon can tell you if he or she can resect, or the absence of invasion into the structure. Some centers support and unblock resection with vascular reconstruction, and that capability may vary from one institution to another. So what might be considered unresectable in one institution might become resectable in another, depending on the level of expertise and how aggressive and the surgeon is and how much experience the surgeon has. Absence of extrahepatic. Obviously, if there is invasion into adjacent structures, you're dealing with unresectable disease, or absence of disseminated disease, so metastatic disease. Outcomes better if it's the lymph node negative. 5-year overall survival for NO versus N positive is 38% versus less than 10%. Pretty obvious. Outcomes are better if the margin is negative. RO versus R1 resection. Again, this is a rare tumor, so obviously the data is all over the place, but the range is 90 to 47% versus 0 to 12%. Bile duct surgery. So this for distal 5-year overall survival is 23 to 50%, and maybe as high as 62%. So like distal, because of the anatomy and not being close to the liver and no liver involvement, in most cases that are not very, very advanced, you're looking at a better outcome with 5-year overall survival as high as 62%. usually lumped. So distal tumors are usually lumped in with ampullary tumors, which tend to have a favorable prognosis. Again, N positive and R1 can confer the worst survival, and that's where radiation oncology will be called. Or in my practice, a lot of cases are just unresectable. So those will also get. So there is data. So for bladder cancer, which we'll cover later, the chemoradiation, there is some data for that. It's very interesting and funny how NCCN flowcharts place radiation as a choice for intra and extra hepatic cholangiocarcinomas and for gallbladder. So when you look at the flowchart, I think looking at it would be things would be much clearer than me saying that. But there is a role for radiation. It's either unresectable or N1 R1 resectable. But that doesn't discount the role for chemotherapy. Adjuvant chemotherapy is very much given for these cases. If there's going to be a resection, if no resection is done, only chemoradiation is done, there is still a role for chemotherapy. You would have a new adjuvant chemo followed by surgery, followed by radiation. Surgery is not good. Radiographic criteria of unresectable perihilar tumors include. So what is T4 disease, right? So if you're bilateral, what I said earlier is bilateral. When you hear the word bilateral, that is unresectable. It's T4, that's unresectable. So bilateral hepatic duct involvement, encasement or occlusion of the main portal vein proximal to bifurcation, atrophy of one liver lobe with encasement of the contralateral portal vein branch that I also mentioned. If you have a complex situation with contralateral involvement, that is also considered unresectable, just for both purposes, makes it easier to remember. Atrophy of one liver lobe with contralateral secondary biliary involvement, duct involvement, and then that would be same situation. Involvement of bilateral hepatic artery, so that would make it unresectable too. Resectability is ultimately determined by the surgery due to the location within the upper hepatoduodenal ligament. These tumors often extend into the liver and major vascular structures, and preoperative evaluation of whether you can resect this or not is often difficult. Surgical exploration is the appropriate treatment for proximal bile duct carcinoma whenever feasible. So this is a very nice chart. We're not going to have time to go over all of it, but just remember for ICC and for Hyler and for ECC, you may need a liver transplantation as your last option. That's it. And an extended radical resection may be required for perihilar cases. And the extra hepatic cholangiocarcinoma rarely require a partial hepatectomy. On the other hand, partial, extended radical resection and partial hepatectomy and regional lymphadenectomy are common for extrahepatic, for intrahepatic, perihilar cases. The criteria for unresectability, we actually went over. And also, in addition to what we went over, if you hear mentions multifocal or bilobar liver disease, just remember bilobar, bilateral. So, hey, chemotherapy for advanced. Again, there is a chart that I'm going to present from the NCCN, but this is what we had from back in 2021, and it still applies because the trials still happen, and this is still applicable. But there's much broader range of drugs that overall we use. So I'm going to go over that in a rapid fire fashion. So you have for advanced, you're going to use GemCis combination from ABC trial, FOLFOX as a second choice, pembrolizumab for MSI-H tumors. We also had this role play out for colon cancer lecture that I had yesterday. For concurrent, what are you going to do? So same thing as for other type of GI malignancies, 5-FU, or which is a continuous infusion versus a BID oral capecitabine, which is more convenient. Adjuvant, you're looking at either capecitabine or gemcitabine. So bile duct for radiation. So adjuvant, consider adjuvant chemotherapy first if you're going to do it. So if the cancer is bad enough that you need radiation, you must require chemotherapy. So consider chemotherapy first. And this regimen, 45 to 50/4, we commonly see it's just a very common regimen for GI with radiation. You'll be given to the pelvis. sorry, not to the pelvis. So sorry, to the tumor bed, and to the draining lymphatics, then you would boost if there is the area of R1 resection of the tumor bed with 50 to 60 gray, depending on the margins, and then you have a concurrent, again, concurrent with cisplatin, sorry, 5FU or capecitabine. Unresectable, again, usually after induction chemotherapy. Uh, example, usually with gemcitabine, there is a gemox combination that we are actually doing on a patient that I have right now, which will be presented later. So after some kind of induction chemotherapy, this patient will have concurrent 5FU slash capecitabine or capecitabine radiotherapy, and because it's unresected, this is the best chance that they have. It's 60 to 70 grade if you try to reach that. Normal tissue tolerance, whatever allows that, and hypofractionation with protons or photons, if you can. Again, I look at the functional status of the patient. If the patient really is in good state, and there is hope that we can encompass everything properly within the radiation field, and looking at the duodenum and see if the duodenum we can deliver radiation dose in such a way that majority of the tumor is getting a really high dose, then I would try to do the longer course. But if the patient, we know that it just looks like a hopeless situation, then I would keep it, 15 fraction hypofractionated regimen. And SBRT, in most cases, if they're getting case that is a non-surgical case, that means the tumor is spread enough in the critical vasculature surrounding vasculature, and so SBRT may not even be an option for these cases. But if it is an option and it can be safely delivered, then 50 grain 5 fractions is what I would do. And really make a really hot plan. So 50 grades, so the tumor would probably be getting 60 to 70 grades with on a linac-based plan but you plan it like a cybernetic plan. Prescribing the dose to the 70 to 80% isotope. Okay, so you have a bile duct radiation, the neoadjuvant, 3D versus. So this study is from Duke. You will evaluate the role of neoadjuvant radiation with for real. RT field, Osler. Yes, 3D versus IMRT, 45 to 51.4 grade, the draining lymphatic concurrent chemo, and then okay, this is just simply going over the radiation field, like what is going to look like. Like went over that. Okay, all right. Sorry for that. So I wouldn't use 3D. I would use IMRT. Then you have what are the 3D fields? Sorry, what are the RT fields? What they should look like. So if you look at the contouring atlas for pancreas from RTOJ 0848, that's basically what you should be using. You can contour the portohepatitis, the hepatico-duodenostomy, or where this would have been the tumor bed, and consider additional liver coverage for any positive hepatic margin for post-op phase. So we went over this, and there is a trial we're going to cover the SWOG 0809. It had a SIB IMRT plan with 45 and 45 gray and 55 gray doses delivered in same fraction, and the elective node received 50.4 gray. The boost, 45 to 50.4 gray. 45 gray would be the elective dose. 50.4 gray would also be elective. Yeah, so that is the elective range, and then the boost to 50 to 60 gray based on the margin. And then these are studies we're not going to go over. And then for adjuvant treatment, there's a meta-analysis that looked at all of the studies, just like bunched together. Sears analysis, randomized trial of adjuvant chemo, and 17 retrospective studies with nearly 7,000 patients that had RT alone, chemo RT cases, all had curative intent surgeries. RO and R1 resection were both included. 5-year overall survival with surgery alone, compared with surgery alone. So they compared whatever treatments were done with surgery alone, and no statistical significance was reached. But then after dropping 2 large registries, then they found benefit from adjuvant therapy. I mean, you can just make any statistic data look good. If you drop something. or you play with the p-value. So I don't know how significant this study is, but this is something that's available, and it showed that chemo radiation showed there was a significant survival benefit for gallbladder and bile duct tumors. RT alone, however, had no benefit. If you must do RT, then have chemo on board with it. And there was an overall survival advantage for any adjuvant therapy in node positive or R1 resection. So that's when we really offer chemoradiation for these cases in adjuvant setting. Overall survival advantage for any adjuvant therapy for R1 resection. So again, these are the cases that will make it to the clinic after surgery. Benefit of adjuvant chemotherapy in R1, possibly detrimental in R0. So if there's an R0 resection, patients may still get, if it would be, I would be hard pressed to believe somebody would have an auto resection with a very locally advanced tumor. I've never seen that happen. But again, chemo is a different story. If we talk about radiation, that's an auto resection. For auto resection, there would be no role. SWOG 0809 was a phase 2 study looking at adjuvant Xeloda, capecitabine, and gemcitabine, followed by chemoradiation with Xeloda, which is capecitabine, for resected extra hepatic cholangiocarcinoma and gallbladder cases, 79 patients, 4 cycles of gem Xeloda, chemoradiation, about 45 grade to the lymph nodes and 54 to 49.4 grade to the tumor bed. And we went over this regimen, the SID plan. 2-year overall survival, RO versus R1 was 67% versus 60%, and median overall survival was 35 months. Then there was a GEM-CIS trial, a GEM-CIS combination that was from the ABC trial. So what are the adjuvant agents we use? You can use GEM-CIS from the ABC trial. You can use FOLFOX as a second line, and then pembrolizumab for MSI-H tumors. Again, a very comprehensive molecular testing is required for patients who are unresectable, and if they're going to get systemic treatment, or for patients who have unresectable disease. So NCCN has a whole very beautiful charts with great details in the section where they write in detail, where they are writing out evidence for targeted therapies, immunotherapies, or what kind of chemo combinations or drugs should be used for this. So it's very important that you get molecular testing done, and we'll quickly go over that later. So adjuvant capecitabine. There's a study called the Bile study. Here it says it was not studied, but actually it's the results are available. So I have that update later on in the PowerPoint. They randomized, in this patient, they had 447 patients with resected cholangiocarcinoma. They randomized the patients to observation versus adjuvant capecitabine. And amongst patients, they had all kinds. They had a gallbladder cancer cases. They had biliary, extra intrahepatic duct cases, cholangiocarcinoma cases. They were was pretty inclusive. 38% had an R1 resection, and 54% of the cases had a node positive disease. And the intention to treat analysis did not show any benefit. However, the per protocol analysis did show benefit. So we'll go over that, what it means. We'll go over that in the gallbladder portion. And PRODIGE 12 study, which was an adjuvant GEM-OX as an adjuvant therapy. You can see that the P numbers don't look very significant for this study, and you can read it up. Okay, then you have locally advanced disease for bile duct. This was a study that was released in the Red Journal back in 1994, and again, it showed that patients who received, this patient, 48 patients with, they were treated with chemo-RT less than 55 gray and greater than 55 gray. There was a 2-year overall survival difference of 48 versus 0%. ABC trial, again, GEM versus GEM-CIS, you can go over that. Okay, so this is an important addition from 2021. is the role of HAI, RFA, TACE, TARE. So what is TACE? It's a trans-arterial chemoembolization, and TARE is radioembolization. And they have both been shown to improve outcomes for unresectable cases. And there is a hepatic arterial infusion with chemotherapy. So again, data from prospective studies support the use of hepatic arterial infusion called HAI in patients with advanced liver confined and unresectable intrahepatic cholangiocarcinoma. In fact, there's a patient right now that got a few cycles of GemOx for intrahepatic cholangiocarcinoma. Unresectable patient came to me and had an appointment to get Y90 done before she gets her chemoradiation. So I'm seeing this in real time every happen. So yes, this is very important for the current practices, and you should be aware of it. In a meta-analysis, including 20 studies, HAI was compared with TACE, drug-eluting beads dash TACE, which is chemoembolization, and TER, which is radioembolization with Y90 microsphere. Overall survival and tumor responses were greatest for HAI, with a median tumor response of 57%, although they were higher at grade 3 and 4 toxicity. Also, a retrospective study showed that for intrahepatic cholangiocarcinoma, patients who received a combination regimen of HAI and another chemotherapy agent like gemcitabine, irinotecan, and pyrethroid had a greater overall survival relative to patients receiving chemotherapy without HAI. And you can go over this, but basically, this is telling you that there is role for these agents. We have to cover the gallbladder in the time we have right now. So you can go over this slide later on, but these are the studies in favor of combination therapies. The combination of chemo and Y90, 22% of the patients were downstage to surgery. And then this is straight from the NCCN, so I'll just go over quickly the stuff that is important. Is patients are not candidates for surgery with curative intent, you can either treat them with these therapies and chemoradiation, or you can downstage them with this treatment. The local regional therapies, in addition to systemic treatment and local EBRT treatment. Local treatments also include ablation, arterially directed therapies, and RP. And so these are the criteria. Like for ablation, you want to make sure that all the tumors should be amenable to complete ablation, so the tumor and a margin of normal tissue up to 1 centimeter can be treated. Thermal ablation is a reasonable alternative to surgical resection, particularly those patients who have a high risk disease. And this is for small tumors less than 2 centimeters size we're talking about, whether they are recurrent or primary. So that's an option. For arterially directed therapies, hepatic tumors may be amenable to this therapy, provided that the supply to the tumor may be isolated without excessive non-target treatment. Select patients with limited extrahepatic disease, so hilar lymph node less than 3 centimeters in size or less than 5 or less, lung nodules less than 1 centimeter or less, may be considered for arterially directed therapies in combination with systemic treatment. And then I went over the rest. This could be used alone or in combination with systemic chemo with the intention to prolong the survival or to downstage to curative resection. Now, this is something that I learned through this. If you're going to use Y90, the goal is to take the dose to greater than 205 gray to the tumor, may improve the outcome. And if you're going to do EBRT along with it, you need to consult with the folks who are going to do this procedure and just make sure everything is well coordinated, both in terms of the planning and the dosing. Y90 is relatively contraindicated in those patients who have a bilirubin level of more than 3, and but grade 3 or 4 hepatotoxicity occurs in less than 10% of the patients, although this may be significantly higher in patients who have cirrhosis. Okay, the role of chemoradiation as a local treatment. Again, there is a role for it. We went over it, and if you're going to do hypofrac, then the dose is at the bottom of the screen in red. It's 58 to 67.5 gray in 15 fractions for a median biologic equivalent of 80.5 gray. So you really have to have really, really, really good dosimetry support, not just a cookie cutter, just like a cookie cutter community clinic. Even in a community-based practice, you can provide really good treatment if you have a really, really good immobilization, really good daily imaging, also have really good therapy team, and most importantly, so you need good team to create a plan and a good team to execute the plan, and also have really great immobilization devices. So really good. So every area, every piece is important if you're going to deliver this in your clinic, or just send the patient to a high level of care better centers that can do it. All right, we're not gonna, because we're running out of time. This is just given for your, you will see wherever you see chemoradiation, if it's R1 resection or positive lymph node, combination chemotherapy with chemoradiation. This is post resection, and then this is, what is the kind of workup that you do for intrahepatic cholangiocarcinoma? So you're going to do all of this. We discussed, the CT, the MRI, CEA, CA, LFTs, esophageal gastroduodenoscopy, the scopes, colonoscopy, viral hepatitis serology, alpha fetoprotein, and a referral to a hepatologist. Then if it's resectable, then you go for a staging laparoscopy and then have a regional, resection plus a regional lymphadenectomy. Consider ablation. We discussed unresectable. These patients go for systemic treatment or clinical trial, and then you can do, you can apply other targeted therapies plus chemoradiation to improve the outcome. So all of that is given here, everything we covered. And then if patient is presenting with jaundice, the first thing obviously you want to do is reduce the jaundice with PRCP, but then you should do everything to stage the patient properly. Again, if you look at the right side of the NCCP, the NCCN guidelines, it's literally similar for all these flowcharts. For resectable, go for surgery, or have neoadjuvant, not in here, but if you have a borderline resectable, you're suspecting you might have an R1 resection, then you do neoadjuvant treatment. Or any locally advanced case, you would be able to justify that. But patients go for resection. When unresectable, again, you want to drain and then get the molecular testing in place, do the systemic treatment, and then, if possible, the chemoradiation and locally directed therapy. Again, so it's multidisciplinary care, right? So post resection, same thing. Again, really quickly, we have 15 minutes, so let's get through this. This should be easier because we have gone over a lot of stuff, so this should be much easier than the other piece of the lecture. So gallbladder cancer, about 12,350 new cases diagnosed, 5,900 in men and 6,450 in women. About 4,000 over 4,500 deaths from this cancer, and approximately 5,000 cases per year. I mean, this was the same statistic that was in the 2021 lecture. So I guess it hasn't increased much, just a little bit, I guess, few hundred maybe. Approximately 5,000 cases per year from gallbladder is alone. Of these new cases, 4 in 5 will be gallbladder cancer. Again, the epidemiology always combines the bile duct cancer from the gallbladder. So, but of those 10 cases, 4. So 40% of the cases that you see for in the biliary tract category are going to be gallbladder. So here it's saying 1 out of 5 cases. But well, 1 out of 5 cases would be at an early stage. That's a really, really low number for an early stage. And I presume this would be more like an incidental finding. The patient is actually getting surgery for a gallstone, but then, boom, you have a pathology report and that says it was cancer. Fifth most common GI cancer, most common biliary tract cancer, usually found incidentally from exploration of cholelithiasis, and rates correlate with the incidence of gallstone. Okay, ECC slash EB incidence is declining, but IS is rising. Incidence steadily increases with age. Alaskans and American Indians, Aborigines have the highest incidence and mortality for all the gallbladder for the gallbladder cancer. Incidence has decreased in females and increased in African Americans and in those in less than 45 years of age. Gallbladder cancer is more common in females. Females are more likely to be diagnosed with gallbladder cancers than males. Gallbladder cancer is also associated with shorter median survival duration, a much shorter time to recurrence, and a shorter survival duration after recurrence than perihilar cholangiocarcinoma. This was important to know. So gallbladder cancer is the most common biliary tract cancer. Majority of gallbladder cancers are adenocarcinomas, and these are all the areas around the world where this is in high prevalence. You have Korea, Japan, South America, Bolivia, Chile. You have India, Pakistan, Ecuador, Spain. These nations have pockets of high incidence for gallbladder cancer. So what are the risk factors? Cholelithiasis is the most prevalent one. Then you have porcelain bladder, basically chronic inflammation, chronic inflammation, cholecystitis leading to calcification. Historically, it was thought that 22% of these cases have gallbladder cancer. However, now there is a debate that the incidence may be much lower than originally thought of, 7 to 15%. Polyps more than 1 cm in size. Chronic infection with Salmonella typhi that gives a chronic typhoid, or you have Helicobacter infection. Congenital cyst. Then you have chronic typhoid infection, primary sclerosing cholangitis, which is also a risk factor for cholangiocarcinoma, and inflammatory bowel disease, which is also the a risk factor for cholangiocarcinoma. Adenomyomatosis is also potential, albeit a controversial risk factor. And then you have abnormal pancreatico-biliary duct junction, anatomic variation where the pancreatic duct drains directly into the common bile duct. Again, I've had this separate on the, the stone size is correlated with the risk. Okay, other risk factors, again, of course, I covered this, so I'm not sure. I already covered this. So most of it, except a patient with a history of chronic cholecystitis or pancreatico-biliary malfunction have a greater prevalence of gallbladder cancers that are microsatellite instability high. The other ones I already covered them. So what are the symptoms? How do these patients present? The chronic right upper abdominal pain, nausea, vomiting, malaise, weight loss. Obstructive jaundice is a surrogate for advanced disease. I talked about it earlier for prognosis. You have, okay, so diagnosis. How is it actually diagnosed? Gallbladder cancer is often diagnosed at an advanced stage, often is asymptomatic in its early stages. It is aggressive once it starts with a rapid spread locally and distant. Clinical presentation mimics biliary colic or chronic cholecystitis. Usually an incidental finding at a laparoscopic cholecystectomy for a presumed benign disease like a stone. About 47% of this, according to one study, 47% of cases present this way. So about almost 50% of the cases for gallbladder cancer are incidental findings. This study is quoted in the NCCN. More frequently on pathologic review following cholecystectomy for symptomatic cholic acid at the initial presentation. Suspicious mass, if seen on an ultrasound, or biliary tract obstruction presenting with jaundice, or right upper quadrant abdominal pain. Jaundice, there is data that NCCN is quoting it for your review. That if you see that, then it is associated with a significantly lower disease-specific survival, and resectability rates are also low as 7%, with even fewer having negative surgical margin, about 5%, and no disease-free survivors at 2 years, according to NCCN references. So pretty bad. Okay, pathology, 76% is adenocarcinoma, the rest are mentioned business adenosquamous cell. Okay, so in accordance for the staging, I'm going to go over it rather quickly, but just know that for the T2 stage, there are tumors located on the hepatic side, and then there are tumors located on the peritoneal side. Tumors located on the hepatic side are associated with a worse prognosis because it is in this part that you don't have a serosa. You have a direct contact between the tumor in the gallbladder and the hepatic parenchyma. So not having a serosa basically is a much easier access. So that's why you have a T2A and T2B. The T2B is the hepatic side, and that's why it's more aggressive than T2A, which is the peritoneum. You can. So this staging is actually not that difficult if you know the anatomy. The anatomy starts with the lamina propria, then you have a muscle layer, then you have a perimuscular connective tissue over that, and then you have a serosa. So T1A is lamina propria. T1B is muscular layer. The moment you hear the word perimuscular, that you're dealing with a T2 disease. Perimuscular connective tissue without involving the serosa, that's T2A. Perimuscular, but it is on the peritoneal side, and the hepatic side would be T2B, like I said earlier. T3 is you're now perforating through the serosa, the topmost part of the gallbladder, and you're going into the liver or one of the adjacent outside structures. So stomach, duodenum, colon, pancreas, omentum. So either the liver or one of the external structures or both is T3. Okay. And or even if you don't have any of this and you just have a perforation through the serosa, that's T3 as well. The perforation through the serosa, invasion of the liver, and or invasion of only one of the structures or the extrahepatic bile. That is T2. T4 is, imagine, just like the cholangiocarcinoma, invasion of the main portal vein or the hepatic artery or two or more external structures instead of just one, which makes it T3, T4. And then you have nodal disease, which is 1 to 3 lymph nodes or more than that would be N2. Okay, and then the workup is pretty similar to what we had for cholangiocarcinoma, LFTs to know the hepatic reserve, high quality contrast enhanced imaging with CT and MRI. CT, so I will just say this, in my practice, I do both MRI and CAT scan. The NCCN hedges on it, but it also tells you, and NCCN acknowledges that both ultrasound and MRI are unreliable in the detection of lymph nodes that are smaller than 1 centimeter in size. And that's why I always get a PET scan no matter what. And although there is no prospective control data to support it, there is emerging evidence from retrospective studies that indicates that it may be helpful, especially for radiographically also regional lymph node enrichment. So if you have a patient who looks like borderline resectable or even resectable, and then boom, you get a PET scan and you find that you have this lymphadenopathy that was either there and not called out, or was just not readily visible. So PET is very, very helpful. All right. Sometimes common sense should take over randomized control trials. Be aware of false positives though, because if you have an inflamed bladder, like for cystitis, any adjacent lymph nodes might be lightened up. But again, whenever in doubt, consider it positive. But in this case, it can really change from a resectable to unresectable. So that's a really, really difficult judgment. So laparoscopy, surgical exploration would be a good thing to do for those two. Jaundice. Again, we went over this. Cholangiography is required for hepatic and biliary invasion of the tumor. MRCP is the preferred choice unless you need an intervention. And CEA and CA19, again, we went over these. Any level of CEA more than 4 or CA more than 19-9 could be suggestive of gallbladder cancer. Just know that CEA is used for colon and colorectal cancer, but it is also could be positive in non-small cell lung cancer. Yes. So very important, these are very non-specific. You can get a baseline, but not for diagnostic purposes. Direct invasion could happen into any of these structures, and then peritoneal carcinomatosis involving the upper abdomen can complicate the case. Locoregional recurrence risk 15 to 20%, recurrence distant 80 to 90%. Okay, so just remember this. What is the treatment? Surgery, surgery, surgery for this entire group, right? Simple cholecystectomy, which is basically you have that and you get a incidental finding of cancer. That's typically done. Simple. Anything more than T1A, you're going to go for a radical surgery. Simple cholecystectomy for T1A, radical cholecystectomy with a lymphadenectomy for anything higher. Chemotherapy for an unresectable or metastatic disease, and molecular testing must be done to see which agent is best used specific case. And chemotherapy also has a neoadjuvant for borderline resectable cases to make them resectable. And also in adjuvant setting after surgery or after chemoradiation, if there is a criteria like node positive or a R1 resection. And also chemo along with concurrent chemoradiation prior to or Zalona. Again, if it's done definitively for radiation, it is palliative according to NCCN. Palliative doesn't mean you should do 30 and 10. You might as well not treat the patient, right? So either you do a really high dose hypofractionated regimen or you do a conventionally fractionated regimen that takes the dose to 60 70 degree with the DVR. Then you have adjuvant treatment for radiation. 3D, I don't know if anyone would be using 3D for this cases. It would be protons or IMRT or SPRT, rarely SPRT. For advanced disease, again, we went over this for the cholangiocarcinoma, so it's the same criteria. Same thing here. Radiation is really not changed from intrahepatic or extrahepatic cholangiocarcinoma. And If you have the expertise available, then you proceed. So here's the thing: if patient, you know, never get a biopsy unless it's warranted. So if a surgeon goes in for a simple cholecystectomy and then finds that, oh, this looks like this is cancer, then immediately, if there is a hepatic surgeon on board in-house, then should be called in to evaluate the situation. And if it is resectable, can be resected. But however, try not to get the biopsy because of concern for peritoneal dissemination. While doing that, a frozen section can be obtained whenever in doubt. These are all NCCN guidelines. If expertise is available, you can proceed with the definitive resection. If you're sure, you can get an R1 resection. If you're not sure about it, so what we need to evaluate is um, there is you should have had imaging beforehand. And if you don't, you should make sure there is no metastatic disease, and you should also make sure there is no unresectable lymphadenopathy or even lymphadenopathy that is not very bulky. Um, Again, the NCCN is not clear on what kind of lymphadenopathy would be a an ideal surgical resection case. But I would assume that at a good center, you'll be able to achieve a good dissection as long as you don't have crazy stuff happening like lymph node right around the celiac axis and invading that entire area, making it unresectable. So that's that. So for gallbladder cancer, just remember this. Diagnostic laparoscopy is not routinely recommended. It is only recommended when after surgery you find, so a surgery that is done for a gallstone, now we find that it's cancer was removed, but with a positive margin, R1 resection, you have a cystic duct margin. Or even if the surgeon knew it was the cancer, bottom line, you had an R1 resection with a positive cystic duct margin, you would go for a direct laparoscopy in that situation. Another one, P3, P4. Basically locally advanced disease or high-grade polydifferentiated disease. And surgery should account for portal lymphadenectomy, hepatic resection. Generally, you will have, with a radical cholecystectomy, you will have a segment 4B and segment 5 removed. But depending on how extensive the margin, basically the goal is to get a clear margin. If you need a more extensive hepatic resection, you need to get that, making sure that you leave out enough reserve for the patient to survive after the surgery. So bile resection only obtained for negative margin, no benefit from routine bile resection for NCCN. What are the absolute contraindications? Metastatic disease, encasing of the hepatic vasculature, medically inoperable, advanced cirrhosis, portal hypertension. It's pretty much similar to what we had for cholangiocarcinoma. Obstructive jaundice is a relative contraindication. Again, you can make it operable if you relieve the jaundice, do neoadjuvant chemo, and then you can see restage the patient. Gross lymphadenopathy, again, like I said, depends on the extent and see how the chemo response is, see if we can turn it into surgically resectability and invasion of adjacent structures. Again, we went over the surgery, I went over all of this actually, and then the dissection of the renal lymph node, if the porta hepatis, do a hepatoduodenal ligament, head of the pancreas and celiac axis. These are the nodes you want to dissect. And incidental finding phase. So biopsy is not necessary. I covered this, I covered this, I covered all of this. So these are NCCN guidelines that actually I didn't realize that I was actually memorizing without my noticing it. So it's available for your review. And I've summarized in this at the top of this slide that no routine biopsy is required. I went over this and I was okay. So you want to rule out disease in the celiac axis and the aortocaval groove because this might make it unresectable, right? So unless because just like pancreatic. Um, but again, this could be borderline resectable too. So you want to look at it, discuss multidisciplinary team, discussion and surgery, and then most likely this patient go for neoadjuvant chemo first. No, or just definitive chemo radiation after neoadjuvant chemo. No surgery. No routine bile duct resection or port site. So port site resection is not going to be effective because if you have an implant at the port site, it's really a surrogate marker for underlying disseminated disease and has not been shown to improve outcomes. And we are getting close. It's done. We are done. The meta-analysis, we went over SWOG 0809, we went over this. And this is actually a very good slide that summarizes all of the method and the findings. We just basically what is the outcome from this study? That chemo RT had a favorable outcome with low toxicity. Results were particularly improved for node positive patients in comparison with the historical control. So a phase 3 trial should be done. For node positive, the 2-year disease-free survival difference was 50% compared with 30% historical control. And the 2-year overall survival, 67% versus 60%, And then there was a difference in node positive cases and node negative cases. You can go over that at your leisure. And there was this landmark trial, a phase 3 study that you must know, the Bile cap, that showed that although this is a study we went over earlier, although the study did not meet its primary endpoint of improving overall survival in the intention mutation analysis, the pre-specified sensitivity and per protocol analysis suggests that capecitabine can improve overall survival in patients with resected biliary tract cancer when used as adjuvant therapy following surgery, and it could be considered as standard of care. And you can go over that at your leisure. We went over all of this. And these are the slides. Again, we're at the end of the presentation. Now all I have is NCCN in 5 minutes. I'm over time, but in 5 minutes, we're just going to go over the NCCN flow charts. So for gallbladder, again, I have hand drawn this with the marker. For unresectable cases, you have palliative radiotherapy recommendations here. But again, palliative doesn't mean 30 grade and practice, right? So even all the regimens discussed are actually in fact palliative. It's called high dose palliative, definitive regimen, but it's still, it should be important. You should tell the patient that although it's several weeks of radiation, it is palliative. It's not curative. They could call it definitive, high dose, definitive. Unresectable, same thing here. Again, so this flowchart, just go over these, okay? Because they will actually help you memorize without rote memorization. And again, R1 resection or node positive disease, you have all these options. Either you just do chemo, which is preferred, or do clinical trial, or you do a chemoradiation with 5-FU or Xeloda, or followed by chemotherapy, or you do a gemcitabine or Xeloda chemotherapy followed by chemoradiation. So there's all you have a so all of these right are possible. Again, there are several pages on molecular testing. Again, it's just like colon cancer. Get the molecular testing in place. Get the MMR, MSI testing, IDH1 and BRAF genes, FGFR2 and NTRK mutation. Make sure you have those in place if you must start a systemic treatment. There's an increased risk of BTC in patients with BRCA mutations and Lynch syndrome. You should know that. You can also get a cell-free DNA test for identifying the mutation. And this is a nice chart from NCCN that tells you that FGFR2 fusion or rearrangement is present. Approximate incidence is 9 to 15% in intrahepatic cholangiocarcinoma cases. IDH1 mutation is 10 to 20% of intrahepatic cholangiocarcinoma cases. And then you have a HER2 overexpression. This is where trastuzumab would be used, or other agents which are HER2 agents would be used. 5 to 20%. Okay. And the rest, like NTRK, is just for the board, but it's less than 1%, very rare. MSIH, the MMR, like MMR deficient, which I covered in detail like yesterday for colorectal cancer. But this one, it's very rare, 1 to 3%. And what's called tumor mutational burden, TMB high, is less than 5%. KRAS, G12C, and RET fusion, they're all. So these, I've just read them once, but they're not very difficult to remember if you have been in practice, but I can understand for both might be difficult. And BRAF, don't forget, BRAF's V600E mutation was also done for colon cancer. And so again, so these are just the recommendations that I just went over, and you can go over these. Basically, exactly what I said is just summarized. I just said it in verbally, and if you want to know the reasoning and what's FDA approved and when, and all the studies, you can go over that. Principles of systemic treatment for gallbladder cancer only. Okay, so for adjuvant therapy, what are you going to give? Category 1 recommendations: Xeloda. Okay, recommended regimens. You have Gem-Cis, Gem-Xeloda, and then for single agent, you have a gemcitabine or 5-FU. So it depends on the functional status of the patient or the patient wants. But just single agent Xeloda is category 1 for adjuvant. So anyone who had surgery, adjuvant, single agent Xeloda. And then you have agents to use with concurrent radiation, which is right up down here. That's 5-FU and capecitabine. And then you have preferred age. Okay, so in the age of targeted therapy and immunotherapy, you want to know for unresectable or metastatic disease, what are the preferred agents? So category 1, you should know this. Gem-Cis plus you're adding durvalumab, just like you add for non-small cell. For maintenance here, you have durvalumab plus Gem-Cis. you can substitute durvalumab with pembrolizumab. It is also category 1. So durvalumab and pembrolizumab, Keytruda, are both category 1 recommendations. And then there are other recommended regimen. Gemcis is also category 1. So you have 3 choices really that are category 1. Just use the chemo Gemcis, or use Gemcis plus one of the two immunotherapy drugs, either durvalumab or you have a pembrolizumab. Okay, and then in certain circumstances, you can use targeted therapy. You know all the tables we went over, the anti-RK, all the mutation. Yeah, you can use targeted therapy specific to those. And then for subsequent therapy for biliary tract cancers, if there is disease progression, the preferred agent is FOLFOX. Just like oxaliplatin in Mosaic trial showed that oxaliplatin was helpful in improving overall survival for colon cancer. The stage 3, we use that. Here, FOLFOX is used for, again, FOLFOX trial is not appropriate for this discussion, but I'm just making the connection here. So that's done for colon cancer. Here, FOLFOX is the preferred regimen as a second line if there is disease progression, but you can also use FOLFIRI, which is also a colon cancer regimen. Irinotecan is used in colorectal. Or you can use regorafenib, which is also an agent used for colon cancer for chemotherapy resistant disease. So that makes sense. And then targeted therapy and nivolumab is a category 2B recommendation. Very helpful chart. And here in certain circumstances, so you have, again, we're getting, I think we have 2 more slides. That's it. NTRK gene fusion positive tumor. I think this is a rare mutation, but it's an interesting one because it also appeared in colon cancer, and the drugs used are because it's targeted therapy is the same drug, entrectinib and lerotractinib. So remember those drugs, and those are I think they're easy to remember. And then for MSIH and dMMR tumors, you use pembrolizumab. For TMB, for high tumors, you use a combination of nivolumab and ipilimumab. That's the category 2B. And for RET gene fusion positive tumors, you're going to use a pralsetinib or a sulfatinib. Those two. I mean, so if you don't identify anything, if you can't remember, these are the 2 names. If you remember all the other names and you don't remember this one, then that's the one for RET. And for BRAF, B600E mutated tumors, same as NCCN for colon cancer mentioned the same drug, dabrafenib and trametinib. And then for CCA and FGFR fusions, you have F for fusion and F for futibatinib and pemigatinib. And then IDH1 mutation, you're going to use a ivosidenib, and then HER2 positive tumor, the trastuzumab plus pertuzumab, like Perjeta, and then you can use a tucatinib plus trastuzumab, again, same as colon cancer. And then you have a RET fusion, which we already covered, and a KRAS G12C mutation positive tumor for which you're going to use a adagrasib. Okay, that's it.